Hi, my name is Cody Wright. I'm a family nurse practitioner student at West Texas A&M University, and I'm here completing my head-to-toe assessment. So as the patient starts, we get a chief complaint from the patient. This patient is here for a physical, so there won't be a chief complaint. But once we got the chief complaint, we will be looking at the previous health history of this complaint, seeing what happened and what was the lead up to cause the symptoms that the patient might be having today. But because the patient is having just a physical done, that won't be talked about here. Next, we would look at general survey. And so the general survey starts once the patient walks in the door, where we're checking for gait, making sure that the patient's gait is not shuffling, that the patient's not limping, hopping, or having any issues walking, that the patient's gait's not wide, and there's not just a real quick pace to each step. Next, we're going to talk about personal medical history and seeing where the patient's past and previous chronic health issues might be. Next, we'll move into patient's family history. From there, specifically the parents' history of their mom and their dad, and then their grandparents, both maternal and paternal. We move into social history, which would involve their history with alcohol or tobacco, anything like illicit drug use. If the patient has a family, what type of job they have, what neighborhood they live in, so on and so forth. We get the patient's vital signs next, and so that would involve blood pressure, temperature, pulse, respirations, heart rate, and oxygen saturation. And from there, we would then move into just the patient's allergies. And so we check the patient's allergies. This patient has no known drug allergies. And from then we'd move on to the patient's medications and what medications the patient might be taking. Now, this patient's not currently taking any medications up to this appointment. And so next we'd move into the actual assessment itself. And so first we're going to look at the patient's head, and looking at the patient's head, we would expect the patient's head to be symmetrical. This patient's head is symmetrical or normocephalic. We would then palpate the patient's head, making sure that there's no tenderness available. Is this tenderness at all?
No.
Okay. So we're looking for lumps, any type of mass, anything that's abnormal. And then we're going to move into looking at the patient's hair. So the patient's hair should show texture, should be full. It shows no alopecia, which this patient's hair does not. And then we're going to look at the patient's hair for brittleness, making sure that the patient's hair is not coming out, anything like that. We're going to next check the patient's scalp, making sure that there's no itching or any type of dry skin, that there's no moles, there's no rash, there's no lesions of any kind in that spot. We next move into the patient's face, and so the patient's face would be expected to be symmetrical on each side. We look at the patient's skin, which her skin's normal for ethnicity. We start to look at the patient's eyebrows, making sure that the patient's eyebrows aren't abnormal in hair growth, that there's no hair missing in those areas. We move into the patient's eyes, and from there we're looking at the patient's eyelids, making sure that there's no swelling of either the upper or the lower. We're looking at the patient's eyelashes, making sure that the eyelashes are moving upward on the upper eyelid and lower towards the lower eyelid. We're going to next, before we get into the eyes, look at the sinuses of the patient. And so I'll palpate the frontal and the maxillary sinuses. Now, is there any pressure in that?
No.
Okay. The patient says that there's no pressure there. So next we're going to move into the actual examination of the eyes. And so we'll start with just a simple pupil examination. This is going over the cranial nerve 2. And so as we start out here, we'll take the light and we'll move it into the patient's view of sight on each side. And so we're expecting the patient's pupils to converge and constrict as the light hits those. Her pupils started at about a 4, and then they moved to about a 2, which is normal. Patient's eyes were equal and round from there. And so as we look forward, we're looking at the patient's eyes specifically. We're going to go back to looking at the conjunctiva and the sclera of the eye. So I have the patient look up as I push down, and then look down as I push up. Patient's conjunctiva is pink, moist, and the sclera is white. Next, we're going to look at the patient's oculomotor, trochlear, and abducens cranial nerves, so which would be 3, 4, and 6. That would involve the scope. And first off, we'll look at the patient's optic discs, making sure that these optic discs are have a good boundary, that they're easily you can easily see the outer edges of those optic discs, as well as you'd be able to see any arterial nicking of the retina, anything that would be abnormal. So what I'll have to do is I'll have the patient look straight ahead. I'll stick my finger on the patient's shoulder here. At a 15-degree angle, I'm looking at the patient's eyes through the scope and trying to use the dioptic, changing the dioptics of the scope to look for any of those changes in both eyes. So I'll look in that eye. Move over and look at that eye. Okay. So next, after we get done with the optic disc, we're going to check the patient's movement of the eyes. And so we'll start out with the 6 EOMs of eye movement. We'll have the patient look at the scope directly ahead. And as I move into 6 different locations, we'll have the patient just look and move her eyes only and not try to move her head. So just follow the scope and not move your head. So what I'm looking for there is making sure that there's no nystagmus, strabismus, anything that's abnormal, that there's no eye that kind of tends to wander in a specific direction. Next, we're going to test the conversion of each eye. And so we'll start, have the patient look at the scope directly out in front. As I move the scope towards her, I want her to continue to just focus on the scope. So as the scope gets close to her, we completely expect her eyes to focus on the scope and move as the scope gets closer into her. Okay. Now, next we're going to go ahead and look at her nose. And so we'll start out with just looking at her nose, making sure it's symmetrical, making sure that there's no septal deviation. We're going to check for the patient's patency of each nostril. And so what we'll ask the patient to do is first put one hand over one nostril and breathe out. And put a hand over the other nostril and breathe out. So the patient's nostrils seem clear as she breathes out. Next, we use the otoscope to actually assess each nostril. So as I'm looking at each nostril, I'm expecting to see an intact septum. As this patient has an intact septum, the patient's nares and mucosal membranes inside each nose is pink, moist. There's no polyps, as well as no exudate. All right, you can put your head down there. From there, we look at the patient's mouth, and so the patient's mouth is symmetrical. We would go ahead and test the cranial nerve 7 for this patient, which is facial nerves. And so we'll have the patient smile and then close her mouth. While the patient close her eyes. Don't let me open it. All right, so patient's cranial nerve 7 is intact there. Next, we're going to have the patient open their mouth wide. This will test the cranial nerves 9 and 10. Okay, so we'll have the patient 9, 10, and 12. So as the patient has been talking to me already, I would know cranial nerve 9 is intact. Cranial nerve 10, I'll have the patient open her mouth, tongue down, and say ah. Ah. Look at the patient's tonsils. I'm looking at the patient's mucous membranes, making sure I'm looking at the patient's teeth. So with this patient here, the uvula has contracted up as she says ah. It is it's midline. It's not moving in either direction. Her tongue is midline as well, not deviated in any direction. Her mucous membranes are pink and moist. Her teeth are clean. There's no signs of gingivitis or infection. Her pupils are a +2. There's no exudate on the pupils, no exudate on the pharynx as well. So next we're going to check cranial nerve 5, which is trigeminal. And so this involves the mandibular joint of each side. So I'll just place my hands on her jaw and have her open her jaw and close it. And then I'll put my hands on her temporal muscles, have her bite down there. And so what I'm feeling for is that her muscles and her temporal area are flexing, that her mouth is going up and down, her jaw is moving, that there's no popping or anything like that. Next, we're going to look at her eyes or her ears, making sure that her ears are symmetrical on each side. I'm going to first look at, so I will check and touch each side or touch around the ears to make sure that there's no pain as I touch. Is there any pain when I touch this ear?
No.
Okay, what about this side?
No.
So that test is specifically related to otitis externa. And so as I'm looking at each ear, I'm now going to check and look at each of the patient's or each ear's ear canal. All right, so on the right ear, I'm noticing that the ear canal is clear, that the tympanic membrane is easily visible. All the structures of the ear canal are there. There's no drainage, no redness, no swelling. So we'll also check on this side. All right, and the same as goes for that ear as well. The ear canal is clear, no drainage, no infection on that side. So also part of checking for the cranial nerve 5, we're going to do a test to let us see if she can tell me which area of face I'm touching. So it'll be six spots here that I'm touching. Now what I have you is have you close your eyes for me. And I want you to tell me if it's soft or sharp.
Soft. 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 Sharp. Sharp. Soft. Soft.
Okay. So that test specifically relates to the trigeminal nerve, which is number 5. All right. So next we're going to go ahead and look into her her neck, making sure that her neck is symmetrical, that there's no abnormal lumps or masses there. I'm going to go ahead and check for all her lymph nodes. So we'll start back in the back. We'll check for the occipital lymph nodes, which are absent. We'll check preauricle and postaurical, which are absent. We'll check tonsillar lymph nodes, submental, submandibular, submental, superior cervical chain, the deep cervical chain, which are sometimes difficult to palpate, as well as the supraclavicular. All those lymph nodes are not palpable, which is a good sign there as well. Next, we're going to go ahead and check her cranial nerve 11, which is her spinal accessories. And so what I'll have her do is have her, I want you to look straight ahead at me here. I'm going to put my hand on one side of your jaw. I want you to push your jaw towards my hand, okay? Very good. Very good. I'll have you shove your shoulders here. That just shows that they're intact, that the sternocleidomastoid muscle is working there with the cranial nerve 11. All right. So next, what we're going to do is we're going to start with the lungs. Let's move back. Let's go ahead and go into the thyroid and the actual neck itself. When I'm looking at her neck here, I'm making sure that the sternocleidomastoid and the trachea is separated here specifically, which it is. The trachea is midline, not separated in either point. I'm going to go ahead and check for goiter or any type of lumps on the thyroid. So what I'll have her do is have her tilt her head just slightly down, coming back here, and I'm palpating the thyroid gland, making sure again that there's no goiter, that there's no nodules or abnormal lumps, which there aren't. Next, what we're going to do is we're going to go into her lungs and check lung sounds. So starting at the posterior side of her body, we're going to make sure, again, just looking directly, that her body is symmetrical, that her lungs are airing up symmetrically bilaterally, so there's no standard deviation as to which side of her lungs is airing up more or less. We're going to go ahead and start with auscultation and listening in different areas of her back here. want you to take a nice deep breath in. And from there, we're going to move into tactile fremitus. And so how that will work is I will just place the bell of the diaphragm of the stethoscope over certain areas, have her repeat something, and listening for hyperresonant sounds, or I should not be able to hear her as clearly as she does without listening to the stethoscope. So, all right, can you say 99?
99.
99.
99. 99. 99. 99. 99.
Okay. So next we're going to do a little bit of palpation and percussion. Just making sure that she's not tenderness at all in any areas in her back here. Are you feeling any tenderness?
No.
Okay. So for palpation, I will just go through each area of segmentation, just checking to make sure that I don't hear any dullness. It should be resonant and full, which it is. If it were dull, I would expect some consolidations in those lymph fields, which I do not hear. I can also do some more fremitus just by feeling. And so as she says 99,
99.
99,
99.
99,
99.
and all. I don't feel any weird vibrations or anything there. Since I'm already on the back here, I'm going to go ahead and check for CVA sign for possible pyelonephritis. And so I would just look back here, kind of find the arc here of her rib or her lungs. I'm going to have just a hand here and do a little bit of tapping. You have any sensitivity there?
No.
And what about this side?
No.
Okay. So next we'll go ahead and move around to the front. We're going to do the same thing with her lungs here. I'm going to go ahead and listen for lung sounds and do some fremitus and bronchophony. So lung sounds are clear. I'm not hearing any wheezing, no rails, no crackles, nothing like that. There was nothing as well on the posterior signs. I would again do some fremitus, having her say 99. Okay.
99. 99. 99. 99.
All right. Next, we'll move on into her cardiac side of this, and so we'll start out with just the heart sounds. And so as I move into different areas of the heart, we're checking for the different valves and what they sound like, checking for murmurs, specifically checking for S1 and S2 heart sounds. The first area we're going to listen to is just second intercostal space. This is the aortic valve, and then we'll move over into the second intercostal space on the left side, which is the pulmonic valve. Then we'll move into the fourth intercostal space on the left sternal border for the tricuspid valve, and finally moving over to the apex of the heart for the mitral valve. So I'm using both the diaphragm and the bell to check for murmurs. And so she has solid S1 and S2 heart sounds, no S3 or S4 noted, no murmurs, No gallops, no clicks, anything of that sort. And so next, with the rest of the cardiovascular health, we're going to go ahead and check for pulses and bruits in all arteries and of the upper extremities. And so we would go ahead and I would palpate the carotids on both sides, which are +2s. After I palpate them, I'm going to go ahead and listen for bruits. So the patient has no bruits or thrills involved with the carotid arteries. I'm going to then check for a brachial pulse. And check for a radial pulse. All right. And so since I'm already in this area, I'm also going to go ahead and check for axillary lymph nodes. And so I'll have the patient just stick her arm out here. And I'm going to go ahead and just feel inside the armpit here. Check on both sides. All right, and no axillary lymph nodes are noted. So next we're going to move on into the abdomen. So I'll have the patient lay back. And first thing, we're just going to just look at and basically inspect the abdomen, making sure that there's no areas of asymmetry here, which the patient doesn't have any. There's no lumps or any noticeable paralysis of the gut. And so then we're going to go ahead and palpate and listen. And listen to each quadrant for anywhere between 30 seconds to 2 minutes. All right. So the patient's bowel sounds are active in all 4 quadrants. I'm also going to go ahead and check for bruits or thrills in the patient's abdominal aorta, in the renal arteries, in the iliac arteries, as well as the femoral arteries. All right, so no bruits or thrills. No bruits were heard, no thrills were felt as we moved over that area. Next, I'm going to do some light and minor palpation of each quadrant. Let me know if you have any pain or discomfort. Okay, any pain or discomfort there? No. Next, we're going to go into more of deep palpation of each quadrant, just making sure that there's no lumps or masses felt in each quadrant. So. So no lumps, no masses are felt at all. Next, we're going to go ahead and we're going to do some percussion, checking the contents of possibly the abdominal cavity. We're going to start again in this quadrant over here. All right. So no dullness noted in any of the quadrants of the abdominal cavity. Next, we're going to go ahead and check for where the liver is. Usually it's not palpated and palpable in most people, but we're going to go ahead and start. And I'll palpate with just her lungs. So starting here, and there will be a dull sounding. And as the lungs end, I can't hear the dullness of the lungs anymore. It goes back to being resonant. And so I know that the liver is underneath and not coming out of or enlarged for hepatomegaly. And next we're going to check for spleen. So we'll do the same thing with the spleen on each side. We'll start palpating the lungs, and as we move down, expecting not to hear the changes, and not hearing the dullness in lower. And again, the dullness ends just about where her rib cage also ends, which means that the spleen is not palpable. You can palpate the spleen by basically placing one hand on this side here underneath the 12th rib, pushing inwards and trying to push the spleen up against the hands, but still sometimes it's not palpable that way, as hers is not palpable either. We're going to go ahead and palpate for both kidneys. And so here we'll have the patient start here, try to push the kidney upwards here and do some forceful pushing into the patient's side. So have him take a deep breath in, and as you blow out, you're going to palpate in and try to fill the kidney. So those are not, the left kidney was not palpable there. And do the same thing on this side. So start out here, take a deep breath in. As you breathe out, I'm trying to palpate there, and the kidney is not palpable on the right side either. So next we're going to go ahead and move into hip flexion and extension. We're going to check for lumbar radiculopathy, and so I'll have the patient lift her leg up this way here, and as I'll have her lift her leg as high as she can. Is there any pain in your spine there?
No.
No? All right. Lift the hand here. Lift your hand leg there. Perfect. Any pain on that side either? So that's basically checking for sciatica or any nerve pain that might be in the lumbar spine. Next we're going to check for hip functionality and see what kind of range of motion her hips might have. So we'll start out with just picking the legs up here, making sure that she's got full range of motion for abduction and for extension and contraction. So then we'll do abduction and then adduction there, and then we'll also just do hip flexion back and forth, making sure that it moves there. Not uncomfortable at all? We'll do the same thing with the other side as well. Flexion and extension, abduction and adduction, and then moving the legs around there. Okay. Next, we're going to check the strength of the knees. So as I look at the knees, I'm expecting symmetrical knees on both sides, no lumps, no masses. Patient doesn't have report any pain in this side. So what we'll do is we'll check as we pick the knee up. We're just going to check that extension and flexion, making sure that everything works there. We're going to check for any abnormal movements there as well. I'm going to check for strength of this. So what I'll have her do is I'll have her just basically pull her heel down. So pull your heel down, and then she's strength there, and I'll have her push her heel out. The function of the knee there is strong. If I were to rate it to be a plus, it'd be 5 out of 5. And so we'll check the other side as well. So go ahead and pull back with your heel. Perfect. And push out. Perfect. Next, we're going to look at her ankle and her lower extremities. And with her lower extremities, we're making sure that, again, they're both symmetrical. They both look the same. There's no dependent edema on either sides. There's no hair loss. There's no arterial or venous insufficiency symptoms, such as, again, hair loss or ulcers, no signs of cyanosis or anything like that. With her ankles, we're going to make sure, I would like for you to just move your ankles around all over. Make sure she's got full range of motion in her ankles. We're going to test strength of her ankles. So as she pulls up here, I'll have her just push down like she's pushing on a driver pedal. Perfect. And come back. Perfect. We'll do the other side as well. Push, 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 and come back. Perfect. All right. So next we're going to have her just sit up here. All right. So we're going to do some neurological testing now, just to check and make sure the function of her cerebellar, check her cerebellar function. So first off, what I'll have you do is we'll do a quick hand movement test. And so I'll have you having your hands out here. We'll be moving back and forth quickly. Okay. So go ahead and try to move your hands forth back and quickly. So what would we expect to see is her hands moving back. Okay, you're good to go there. Her hands are moving back quickly. If she had some sort of cerebellar disease, it would move much slower than that. Okay. Next, we're going to check for to see how well she can recognize what I'm drawing on her hands. So what I'll have her do is have her hold her hand out here. This is called stereopathy. And so basically what she'll do here is she'll close her eyes, and I'll draw something on her hand. And she'll tell me what that is.
At 3.
Okay. Perfect. All right. And so now what we're going to do is I'm going to have her stand up. We're going to do a Romberg's test. And so let's have you stand up for me here. Face the camera. And so I'll have you close her eyes. So as she closes her eyes, I'll have her raise her hands out all the way out here, both hands. And so she'll close her eyes. I'm expecting to watch and make sure she's not going to fall. Open your eyes. Close your eyes. So I'm specifically looking at making sure that she's not moving in drastic changes or losing her balance as she's moving. Okay? So we'll go ahead and put your arms down there. You can go ahead and turn around. We're going to check her spine. All right. And so as we would check her spine, we'd have her bend over. And so we would follow her spine back as she goes along this way, making sure that it's not moving in any specific way. We're also going to check and make sure she's going to go back halfway, checking her spine there, making sure it's going to come back halfway. As she sits all the way up, I'm looking at her shoulder height, making sure that one side's not higher than the other, which would be indicative of scoliosis. Okay. Have a seat right here for me. So next we're going to go ahead and check for reflexes. And so we'll check the major reflexes here. Well, first we'll start out with her triceps reflex. So come out here. Check it out here. All right, there's one. Check it over here. Very good. We'll check the brachial reflex. So right here. Very good. Very good. Next, we're going to check for patellar reflexes. Good. Good. And finally, we're going to check for the Achilles reflexes here. All right. And finally, we're going to go back and test for ocular cranial nerve 8, which is hearing or acoustics. We're going to go back and look at the whisper test as well as the Weber and the Rhines test. And so for the whisper test, I'll close one of the opposite ear, and I'll just whisper something for her to remember. 3 UI.
3 UI.
Okay.
CWX.
All right. And so she got both of those correct. And so next what I'll do is the Weber test, which is testing for conductive hearing. And so I will just get the tuning fork on the end of my hand there, stick it on the middle of her skull, and making sure, can you hear both ears equally?
Yes.
Okay. And so the patient should be hearing both sides equally there. Next I'm going to do the Rhines test. So what we'll do is we'll hit the tuning fork. We'll put the tuning fork on her mastoid, and then let her know, just let me know whenever you can't hear it anymore, and then we'll move it to your ear, okay?
Okay. Okay.
Okay. So as we look at that should be a 2-to-1 ratio. Next what we'll do, we'll just continue to do it on this side.
Okay. Okay.
So finally, the last thing we do before this exam's over is we're going to go ahead and redo the strengths of her upper extremities. And so what I have her do is I'll still have her stick her hands up towards me at an angle here. I want you to pull back towards you. Perfect. Push. Perfect. We're going to look at her wrists, making sure that they're, so as she pushes here, okay, pull back there. Perfect. Push here. Perfect. Pull back there. And finally, again, shoulders are out wide. I'm going to push out there and push back in here. There you go. Perfect. Okay. That's the full assessment. So have her get up, and walk off. And so next we're going to talk about the male and female genitalia as well as breast and rectum. So for the male, originally we make the patient feel comfortable. The patient's draped and the patient understands what's going to go on. Have the patient standing. And we're first going to check the shaft of the penis and as well as the the meatus of the penis, making sure that there's no abnormal lesions or bumps there. If the patient has a foreskin, we'll go ahead and pull the foreskin back, checking for phimosis or tightening of that pulling. We're also going to check for hypospadiasm of the urethral meatus, making sure that it's in the correct spot for the patient. We'll move on into the scrotum of the patient, where we will check for lumps or masses in the scrotum, the testes, and the spinal or in the spermatic cords, making sure there's no lumps or abnormal warmth areas. We're also going to check for tenderness, making sure there's no twisted cord or anything like that. For female genitalia examination, we'll first start out with making sure that, again, the patient's comfortable, the patient understands what's going on, and the patient knows what's coming next. We'll have the patient in a supine position, seated back with legs abducted. We'll first start out just by examining the patient's genitalia, looking at the labia minora, looking at the vaginal opening, the clitoris, and those structures, making sure that there's no, again, lesions or swelling of any kind. Next, we're going to insert the speculum into the patient's vagina. We'll first start out with just lubricating the speculum, also as well as making sure that the speculum is warm. We'll have the patient, we'll touch the patient, making sure she knows that we're coming we're going to continue this exam, and we're going to put the speculum on the patient's leg to make sure she knows what it's like to feel the speculum. We'll use our left hands and 2 fingers to insert into the vagina, and then we will slightly stick the speculum into the vagina at a downward motion. We'll then turn the speculum at a 90-degree angle, insert in the speculum nice and slowly until we reach the cervix, where we will rotate the speculum and get a full view of the cervix, where we will look for any type of discharge, any abnormal findings there. We'll go ahead and do a pap smear for the patient, and then as we slowly pull the speculum out, we'll be making sure it's not closing too quickly or too early, making sure that we are noticing anything in the vagina as we pull that speculum out, so any types of lumps, masses, anything that's abnormal. Next, we can do a bilateral exam for the patient. So basically, you just take a glove and lubrication. So you stick 2 fingers into the vagina and have the patient breathe in and out, pushing, first off, putting pressure posteriorly with the right hand, and then pushing into the patient's abdomen, feeling for the patient's uterus, feeling for the patient's cervix with the right hand, feeling for the patient's the patient's ovaries, making sure there's no lumps, masses, or anything like that. Finally, the rectal exam for both female and male, they can be laying on their side. So what we're looking for, we'll have the patient bear down initially, just checking to make sure there's no hemorrhoids, no fissures visibly. Next, we'll put some lubrication on our finger and push directly into the anus of the patient, and pushing, letting the sphincter relax, and then moving forward. We'll be making a sweeping motion with the finger, checking for any abnormal polyps or lumps, anything out of the ordinary. And then for males, as we reach the prostate, we'll reach the prostate and making sure that we're rubbing our hands along the prostate, looking for any lumps, making sure it's a normal size and not swollen, or there's not any lumps, no discharge. For the female rectal exam, it goes along with their vaginal exam. You can do a exam there where one finger goes into the rectum, which would be the middle finger, and the vagina, the index finger goes into the vagina, pushing in and feeling on both sides, checking for the tissue in between there, checking for lumps, masses, or anything that might be abnormal. Thank you.